So we're going to review background material from last time. We'll talk about the anatomy of the conduction system and how an EKG is generated. We'll talk about lead recordings, then we'll talk about the system. We talked about atrial rhythms last time. We're going to add AV conduction to that this time, okay? So that's how we're going to proceed. So recall that the conduction system of the heart, which is the electrical system that generates the impulses that cause a physiologic cardiac contraction, is composed with a few components. The SA node, the sinoatrial node, is generally the pacemaker that God gave you. It sits between the superior vena cava, right as the superior vena cava dumps into the right atrium. So it's high in the right atrium. So it's at the right part of the right side of the heart, the uppermost part of the heart. After an impulse is generated at the SA node, it propagates through both atria without any. There's no particular specialized conduction cells throughout the atria. The impulse just sort of propagates through the atrial tissue like a pebble in a lake, like a wave after a pebble in a lake. Okay. And when it hits the AV node, the atrioventricular node, is the only place between the atria and the ventricle where there is electrical continuity. Everywhere else, there's electrical isolation from the atria and the ventricle. The only place where there's conduction is via the AV junction apparatus, which starts with the AV node. So the AV node is depolarized by this wave of depolarization that travels through the atria. It gets activated, and it serves two main functions. First of all, it receives that impulse, it delays it a little bit, pardon me, and then it distributes it to the ventricle. So that's the AV node's purpose. The first little exit to that is called the His bundle, and then it ends the left bundle and right bundle branches. And hopefully when this happens, this is rather speedy. So this is the electrical autobahn of the heart, and it allows the conduction to propagate very quickly throughout the ventricles in such a way that the entire heart should be depolarized at the same time, and hopefully come up with a nice coordinated contraction. So that's what the conduction system looks like. Recall that every cell of the heart has the capability of being the pacemaker. It has a defibrillation pattern. If you record the electrical activity within a single cell, you can do that. Every cell in the heart will depolarize, is capable of being the heart's pacemaker. It's just that the SA node tends to do it faster than everything else. And it's the addition of all of these various potentials within the heart that generates the surface electrocardiogram. The property of being able to generate a depolarization, which is a change in the electrical potential across the membrane of the cell, is termed automaticity. Right, so that's the automaticity of that damn bird. It's the dumbest bird on the planet. Okay, so this is just another representation of that very thing. That the surface EKG is composed of an addition of all of these various potentials. The 12-lead EKG, which is what we usually are looking at, is a recording of all the electrical potentials from the surface of the skin in various locations with respect to time. Remember, voltage is on the y-axis and time is on the x-axis. Voltage is a measure of potential electrical energy between 2 points in space. So there's a reference point which is negative, and then the or ground, and then the recorded potential is the positive pole of the lead. The 12 leads are arranged on the left side of the page as the limb leads, and on the right side of the page is the chest leads, which we'll talk about directly. Remember that an EKG, so I think I showed this exact one actually. This is what the EKG tracing looks like. This half being the so-called limb leads, this half being the chest leads. Every piece of information on this page is important except for this. Remember that? We're covering that up because, as you can see, this is incorrect. And it's typically incorrect. It's very commonly incorrect. The only time it's ever right is when it says normal. Pretty rare. Remember that this little first deflection is a one. It shows you how many little boxes make up a millivolt. So there's 10 millimeters per millivolt. Recall that that can be half standard if the EKG, let's say somebody has horrible LVH and the QRS complexes would be this tall and start to overlap one another, you can create it to be half standard. So it's worthwhile to look at this to see if it's 10 millimeters and that would be standard. It's also helpful to see the run rate of the paper speed rate, which is usually 25 millimeters per second. That means that 5 big boxes becomes 1 second, and each little box is 0.04 seconds. That sort of allows you to be measuring in the usual sort of way. It doesn't have to be that way. You can make it different. And in fact, some of us demo cardiologists will sometimes make it really fast paper rate so that you can really accurately measure the timing of all the electrical events. And sometimes you compress it like on a Holter monitor where you can see a whole day's worth of QRS is on one page. So a standard EKG is 10 millimeters per millivolt and 25 millimeters per second. Those are the standard settings. But it's valuable to know where that is and what that means. Okay, the 12 leads, recall that we talked about the limb leads, Einthoven's triangle. From right arm to left arm is lead 1. From right arm to left leg is lead 2. From left arm to left leg is lead 3. And then AVR, AVL, and AVF are sort of tying 2 of the limbs together to be ground and then positive in the other direction. The chest leads are arranged with V1, V2, 4, 5, and 6 along the 5th intercostal space, and then V3 just kind of somewhere in the middle between V2 and V4. That's how you set them up. It should be the same every single time. With the patient lying down. EKGs are not to be done with somebody sitting up. That's not the way you learn how to read them. It changes all the measurements. So it's got to be recumbent, down, flat. The concept of axis, I don't think we talked about that that much last time. But it really has value when you're trying to decide about certain diagnoses, like right ventricular hypertrophy or left ventricular hypertrophy. I'll introduce the concept and we'll talk about it more as time wears on. The purpose of axis is usually talked about in terms of the QRS axis. So axis is a directionality. It's like if you could look, and also axis is only a limb lead phenomenon. It's not a chest lead phenomenon. So you're only looking at the 6 limb leads, to decide what the axis of the QRS is. Now there is such a thing as a P-wave axis and such a thing as a T-wave axis, but for the most part it is a QRS axis that you're after. Somewhat arbitrarily, it's a 360-degree circle going sort of, and this is 0. This direction is 0. And it goes positive in this direction and negative in this direction to plus 180 and minus 180 over here. So what is the axis? It is, if you could draw everybody knows what you remember geometry class where we talked about like rays, so that if you could pick a ray that points the direction of most of the voltage for a QRS complex, that's what it means, sort of the direction that the depolarization travels. And most of the time it's going to be basically in this direction, right? From the AV node down to the apex of the heart. So a normal axis is said to be between minus 30 and plus 90. So that means that the axis will be between the direction of where AVL goes and AVF goes. Recall also that that since the P wave is in the high right atrium, the directionality of that depolarization is going to also be in that sort of general direction. And if you look at where lead 1 and lead 2 go, it's going to kind of be in between those two. Remember, that's how you define sinus rhythm. So we'll talk about this a little bit more as time wears on. It can be somewhat complicated, and I would rather just introduce the concept today and let's not sweat it too much. Remember that there are various measurements that you make on an EKG that are useful in diagnoses. There's the so-called PR interval from the beginning of the P wave to the beginning of the QRS that includes the whole sort of lump of the P wave. That PR interval talks to you about what the 80 node conduction looks like. The QRS interval is the width of the QRS. That tells you about the ventricular conduction system. QT interval is from the beginning of the Q wave to the end of the T wave, and that tells you about repolarization. Most commonly, this you're worried about if this is prolonged, that if somebody has prolonged QTs or things that make a person susceptible to bad heart rhythms. The ST segment, the fabled ST segment from the end of the QRS to the beginning of the T wave, this is where you look for ischemia and infarction. The PR segment from the end of the P wave to the beginning of the QRS. I don't know why they don't call it the PQ segment actually, but it's called the PR segment. Different than the PR interval. It is really the only real thing that I can think of that is useful to look at that is if it's depressed in the appropriate clinical setting, it's almost pathognomonic for pericarditis. And then the TP segment, which is basically the end of the T wave to the beginning of the next P wave, is the sort of isoelectric. When you're measuring whether or not any of these segments are up or down, see the flat lines? They should all be, this is the 0 point. So if this is higher than this, that's abnormal. So this is the so-called isoelectric line, or the place where it's 0 deflections one way or the other for the most part. All right. We talked about the system last time, and this is my system. It does not have to be your system. But my system is I identify the atrial rhythm first. I look at the ventricular rhythm, and then I see what the relationship is between these two things. Then I look at the patterns of conduction, look for ischemia, infarction, and then for other stuff. And this is often the messy part, but to be truthful, I mean, if you can get that part, I mean, you've done it pretty good, So that's what we're gonna look at. So that's my system. Atrial rhythm identification. So remember that there are, as we talked last time, there's not a million options. There's a few options for what the atrial rhythm is. And so you've got to look at the EKG. I find that it's best to look for the atrial rhythm first, because very often if you look at the great big squiggles on there, you get distracted and your mind wanders off. So for me, it's better to look at the atrial rhythm first, and then it gives me better context for interpreting the rest of the thing. So I'm looking for those P waves, assuming that there are P waves, and sometimes you got to find them. Sometimes they're hidden in T waves, sometimes they're buried in the QRS complex someplace. So you got to go on a search for P wave, or atrial activity. Remember that the options are really only 6 things, and other things that are sort of categories of this very thing. So there's either no atrial rhythm, there's sinus rhythm, there's an atrial rhythm that's not sinus, atrial fibrillation, atrial flutter, and then it's like retrograde atrial activation from somewhere else. So that's it. I mean, that's it. You only have to worry about those things. It's kind of nice, right? You can get all the way through the first part of the system knowing those things. Once again, defining sinus rhythm, the sinus node is found high in the right atrium near the junction of the right atrium and the superior vena cava. The area is called the crista terminalis, for those of you who feel like being anatomy nerds. In this location, so if an impulse is derived from that particular part of the heart, then the inscribed P wave on the EKG will in lead 1 and lead 2 be upright. Period. Unless the patient has dextrocardia. It's going to be upright in 1 and upright in 2. So if you have a P wave on the EKG, it's upright in lead 1, upright in lead 2, with a rate between 60 and 100, normal sinus rhythm. Done. Has to be. All right? Now, as my disclaimer was, it is theoretically possible to have an atrial rhythm where the atrial rhythm is being generated just slightly outside of the sort of SA node and is not sort of technically exactly sinus rhythm, but those are pretty uncommon. And that's, you need to get trained professionals involved if you're going to try to sort something out beyond that. But I think for 9,999 out of 10,000 EKGs, this rule holds, okay? All right, so we've defined sinus rhythm. Atrial standstill means there ain't no atrial activity, so let's move on to the other one. So atrial fibrillation, most of the time with atrial fibrillation, you can see the atrial activity. It's usually chaotic. There is no organized sort of pattern to the squiggles between the QRSs. The ventricular response is typically irregular. It does not have to be. Does not have to be. But it's typically irregular. And there doesn't, so if AV conduction is intact, there won't be a pattern. If there is a pattern, if the QRSs are very regular, there's heart block. Has to be. No other option. Okay? If the QRS is wide and regular with underlying atrial fibrillation, it's a ventricular source. If it is narrow, it's an AV junction source, meaning that it's a junctional escape rhythm with complete heart block. Period. Atrial fibrillation will, by definition, with intact AV conduction, be irregular. For sure. Okay? The ventricular rate can be fast, slow, or normal. And you look, and you remember the TP segment, the isoelectric line, that's the best place to look for fibrillatory waves. So between a T wave and the QRS. It's not really a P segment because it's not a P wave, but you know, it's sort of in that segment. I'm sorry that isn't all that clear, is it? That's what it looks like. You guys have seen it a million times. Usually not that hard to sort out, to be honest with you. Flutter is often a little different. So again, with flutter, there's always, let me restate that. With flutter, the atrial activity is usually, it's more organized and tends to be of higher voltage, so it's usually more easily seen. It is, the characteristics of atrial flutter is you can look at kind of the peak to peak between the flutter waves or the valley to valley, it doesn't make any difference. The rate is almost always going to be exactly 300 beats a minute, which is going to be one big box. So here's a couple of flutter waves. If you measure the distance between here and here, it's going to be one big box. And it's, the ventricular rate is almost always going to be it isn't a multiple, it's a divisor or something of 300. So it's, you know, 150, 175. It's going to be one of those numbers. It almost always is the case. The only time it's not the case is if somebody happens to be on an antiarrhythmic and the flutter rate will be a little lower than 300. So you can alter the flutter rate with antiarrhythmic drugs. and that will make the ventricular rate a little slower. But in somebody that's not on antiarrhythmic drugs, the flutter rate is almost always 300, and the ventricular rate is some divisor of that. The ventricular response is very frequently, in fact, I would say almost always, but not always, almost always perfectly regular. Regular. All right? So very different than atrial fibrillation. It's going to be spot on regular most of the time. Typical flutter, which is a right atrial phenomenon, a macro reentrant circuit, so there's a little short circuit that goes on in the right atrium in a particular anatomic position in the heart that is very well known to guys like us, is it will give you this sawtooth pattern. You don't have to have the sawtooth pattern. It can look different than that, and if it does look different than that, it is so-called atypical flutter, which means that sometimes coming from the left atrium, it is much harder to ablate. If you show this to an electrophysiologist, you're going to have to give him a cup to catch all the saliva because he wants to ablate this so much. You know, so this is an easy, simple ablation that is 97% of the time curative. So this is what they're after, man. They love looking at that. So I will tell you that I sometimes hear that patients are going flopping between atrial fibrillation and atrial flutter. Almost never happens. Almost never happens. I don't want to say never because never is a strong word, but almost never happens. You're either in one or the other. All right? And you should be able to figure that out. To use your clues. If you see the sawtooth pattern, great, then it makes it easy. You can also look at the regularity of the ventricular response. That is also a clue. Not always 100% helpful, but it should be. If it's 100% regular and you think it's fibrillation, there's got to be a reason, right? Like complete heart block. So, you can tell the difference between atrial fibrillation and atrial flutter almost always. Atrial flutter sometimes is difficult to discern from other forms of supraventricular tachycardia, particularly if the rate is 150. If it's ripping, man, it's you know, the QRSs are so close together you may not be able to see the flutter waves. And what might you do to help sort that out? Valsalva, carotid massage, vagal maneuvers, that's outstanding. That's exactly right. That's one. Another thing is to give the patient a dose of adenosine. You know, adenosine is the safest drug in the world. There is not a safer drug, period. It creates complete AV block for about 8 seconds, right? So you'll be able to see the atrial activity for sure. If it's an SVT, it will break it. But it is metabolized by enzymes that are found in red cells. It is the safest drug in the world, and it will go away like this. The trouble with adenosine is it's most often not given correctly. So it is not IV push, it is IV slam. And follow up with at least 20 cc's of saline as fast as you can push it.
You gotta warn the patient though.
What's that?
You gotta warn the patient because they usually feel like they've been kicked in the chest or
They
like
can.
they're gonna pass out.
Most people are already feeling their SVT, so they actually feel pretty nice about it. I mean, you know, most of the time. So it, you know, it can make you a little shorter breath, it can give you a little pain in your chest, but it goes away so quickly that it is incredibly safe. You just have to be recorded. I actually think it's best to record a 12 lead while you're doing it because you'll get all the information there laid out for you, right? So run the 12 lead EKG, slam it home, and then you'll be able to tell very often, and sometimes fix the problem. So this is an example of an atrial tachycardia not of sinus origin. It's a little bit of a, it's a typical atrial tachycardia is one where there's one focus and it's just ripping along. But this is one that sometimes, I got to tell you, the most common diagnosis that this is probably missed more than anything else. it's called atrial fibrillation all the time. Well, it's a narrow, complex, fast, irregular rhythm. But it means something very different. I mean, how many of you want to take Coumadin if you don't need it? You're going to guess that's a short line, right? I mean, that's not a line you're going to sign up for. So MAT, multifocal atrial tachycardia, is a condition where various places within the atria are trying to be the pacemaker. It almost always happens in people with underlying lung problems. There is clearly organized atrial activity, and this is the difference between it and atrial fibrillation. And if you look on the rhythm strips, you can see these sort of P waves marching out, going along, and they're before every QRS. There's no question about it. That's atrial activity that is organized as opposed to disorganized with atrial fibrillation. Multifocal atrial tachycardia means that it's coming from different places. So the P waves are going to look different. Some places they'll be upright, some places they'll be down. The PR intervals may be short, they may be long, they'll be all over the place. You have to have at least 3 different P wave morphologies on the EKG, on sort of the block of the EKG, in order to make this diagnosis, and none of them can be dominant. Now, very often there's like 5 different P wave morphologies at least that you can discern. The most important thing about this is you don't want to be giving this person anticoagulation because you're not helping them one bit. So they're not at risk for intra-atrial clot that produces stroke. Occasionally, you'll see this rhythm when it's not tachycardic, and it's usually because I've gotten to them and started them on a beta blocker. Then some people will call that wandering atrial pacemaker, where it's MAT without the T part, in other words, the rate's controlled. I would caution you against using the term wandering atrial pacemaker, because that is a very specific diagnosis that is rarely seen, actually. I prefer to call that a multifocal atrial rhythm. If it's not tachycardic any longer, then you can't refer to it as a tachycardia. But wandering atrial pacemaker is something that people will use sometimes to refer to multifocal atrial rhythm, and that is an exceedingly, it's more rare than type 2 second-degree AV block. Just clue you in about that. It's exceedingly, in fact, I've seen it once, wandering atrial pacemaker. That's pretty uncommon. So this is an example of a narrow complex tachycardia with organized atrial activity that's irregular, and it's not AFib. And there are serious consequences to missing that, right? If you start somebody on a blood thinner and they don't need it, they have a 2.5% death rate from bleeding, right? It is significant. You do not blow this one. So it's very important to be very precise about this and to look for it. All right, we talked about atrial rhythm that was multifocal, one that's unifocal. All right, the same P wave morphology all the way across, right? It's upside down in lead 2. Boom, not sinus, period. It's not sinus rhythm. It's sort of isoelectric in lead 1, so the axis for this thing is probably straight up. So the PR interval is really short. So the origin of this thing is like right next to the AV node. That's where it is. That's where and you can ablate these things. They are notorious. This is one of the hardest heart rhythms to deal with because it can be ripping fast. It doesn't have to be, but very often it's going really fast. There's not a reentrant place to sort of affect its propagation or initiation. Antiarrhythmic drugs work poorly for these things. Beta blockers work probably better than anything, but this is a common SVT that is difficult to deal with. This is one of the banes of our existence. Occasionally, when it's like this, it's in the right atrium and it's probably right next to the AV node. It can be ablated on occasion. Okay.
I have a quick question. So if we see the atrial tachycardia, how are we, well, and if it's fast enough, how do we know it's not multifocal atrial tachycardia?
All right, so in this case, all of the P waves are exactly the same. Whereas with multifocal tachycardia, they're all over the place. There's some of them that are upright, some of them are down, some of them have a long PR interval, some of them have a short PR interval. So, and it's irregular.
Okay. All right,
Yeah.
thank you.
MATs are almost always irregular. Atrial tachycardias are almost always spot on, and they're so-called long RP tachycardias. When we get into, in a year from now, we'll talk about what that means. I shouldn't have used that term, sorry. In a year from now, when you guys are really good at this, then we'll get really good at it. All right, so AV conduction. All right, much like atrial rhythms, AV conduction has a few options. Not 100 options, 4. It's either normal, partial, or complete AV block. Normal, partial block, or complete AV block. And there can be non-AV junction conduction pathways. So there are, and that means that there's an accessory pathway, which can also be referred, there's a bypass tract. There's an abnormal conduction between the atria and the ventricles. There's not supposed to be. The only place where there's connection between the atria and the ventricles in the normal heart is the AV node. So if there's another little wire hanging out there, that's going to give you SVT very commonly. And there are several kinds of AV reentrant tachycardias that are, one of them's Wolff-Parkinson-White. I'm sure you all have heard of that. There's a couple of them. But so those are the 4 options for conduction between the atria and the ventricle. That's it. There are no other options. All right. So we kind of skipped over looking at the ventricular rhythm because in part it's evident unto itself. But we'll, for the time being, we're going to talk about AV conduction. And so what does normal mean? The question in your mind should be, is there a QRS after every P wave? Not is there a P wave for every QRS, is there a QRS after every P wave? If not, there's heart block. Period in this story. Okay? Normal AV conduction means that there's a P wave after every QRS and the PR interval is less than 1 big box. That's it. Nothing else. It's not any more complicated than that. If there is normal AV conduction, there is a QRS after every P wave, and the PR interval is less than one little box or 1 big box or less. That's pretty good. Partial AV block means that there is some relationship between P waves and QRS complexes that doesn't meet this normal definition. Okay? So if it's not this, it's got to be this, or it's got to be block of some kind. So there's, so to start with, first and second degree AV blocks. First degree AV block means that there is a QRS complex after every P wave, but the PR interval is longer than one big box. Pretty easy, right? Not hard. Second degree AV block means that there are fewer QRS complexes than there are P waves, and there's 2 types. The first type is Winke block, or type 1 second degree AV block, and then there is type 2 second degree AV block. And I would tell you that if you want to make that diagnosis, better be very careful. It's rare. I'm telling you, maybe you've seen it 3 or 4 times in 25 years. Very rare. Very rare. Almost always, when this is present, the QRS looks really wide. There's other conduction system abnormalities. It is a pre-complete heart block sort of rhythm. You know, it just doesn't happen very much. There's almost always long PR intervals. QRS is like this wide. I mean, there's clearly a lot of conduction system disease, and this type 2 second degree block is a pre-complete heart block. It's like the next step to complete heart block. Complete heart block means that there is no relationship between atrial activity and ventricular activity. Now, I should say this a little bit better, because there's two terms that are used interchangeably incorrectly, and that's AV dissociation and third-degree AV block. So third-degree AV block is a subset of AV dissociation, but AV dissociation means that there's no relationship between the A and the V. Right? The P waves are marching along, the QRSs are going along. What if there are more QRSs than P waves? That doesn't mean third-degree AV block. It means there's an accelerated rhythm of some type that is marching along without talking to the atrium. So that is AV dissociation. It's termed complete or third-degree AV block when there's more P's than QRSs. Although that's also a subset of AV dissociation. You understand what I'm saying? Did that confuse you too much, or did it? Okay. There's an atrial rate and a ventricular rate, and you should report it as such. There could be normal sinus rhythm, third-degree AV block, ventricular escape rhythm at a rate of whatever, and it's usually slow. Remember that every cell in the heart has a potential to be the pacemaker. The typical ventricular escape rate is about 40, 45 maybe. The junctional escape rate is usually about 50 to 60, and obviously the normal sinus rate is somewhere usually between 70 and 80 or so. All right. So those three are pretty easy, right? I mean, there's either normal conduction, partial conduction, or no conduction. First degree block, again, when you're talking about AV conduction, is there a QRS after every P? The answer is yes. Bigger than one big box. First degree block, done, move on. Winky block. This is my favorite rhythm, by the way. And I'm going to tell you why here in a second. So, marching right along, P waves, very regular, upright in 1 and 2. Normal rate, this is normal sinus rhythm with type 1 second degree AV block, or winky block. In this particular EKG, you may want to take a swipe at why it's going on, because the diagnosis is there. That's exactly right. Inferior ST elevation myocardial infarction, commonly associated with high vagal tone, commonly causes winky block, second degree block. Exactly right. Inferior ST segment elevation. So the diagnosis list here is normal sinus rhythm, type 1 second degree block, inferior wall myocardial infarction. Done. That's the entire diagnosis list. All right. Now I have to tell you about this guy. So you're going to get the history lesson. I'm sorry, forgive me. So he's a Dutch anatomist, professor of medicine. He described an intra-atrial conduction pathway that bears his name as well. Legend has it that he determined this rhythm, winky block rhythm, by watching the jugular venous pulsations to determine when the atria were contracting and feeling the pulse simultaneously. And he could tell that the PR interval, if you will, was lengthening and then dropped by doing a physical exam. He described this in 1899. Our buddy, Mr. Einthoven, recorded the first EKG in 1901. He didn't have an EKG. That's a damn doctor there, man. That is right. that is amazing. Just to tell you, he came from pretty good stock. His father developed the first telegraphic communications in the Netherlands. His brothers were national officials and painted all sorts of things that would show up in museums all over the place. His son was a sculptor who designed Dutch coins that were minted as late as a couple of decades ago. So it's a pretty impressive gene pool here. He is actually my favorite historical medical person for this very reason. That is just psychotically impressive. So, get a really good look at it. You may never see it again. So, P wave, P wave, P wave, P wave, P wave, P wave. We're missing a QRS. So, one way to tell for sure about whether or not something is a winky block is you find the blocked P wave. There's no QRS after this, right? The next thing's another P wave. So here's the blocked one. Put your finger on it. Look at the QRS after, the PR interval after, the PR interval before. If this one's shorter than this one, it's winky block. All right? Let's blocked P wave, PR interval after, PR interval before. PR interval before is longer than the one after. Winky block. Done. Make it that simple. You don't have to like measure it out. Is it getting bigger? I'm not really sure. Look at the blocked one, the one after. If it's shorter than the one, the PR interval before the block, winky block. Finished. Okay? All right. Sometimes you'll see this, where it's twice as many P waves as there are QRSs. This is so-called 2 to 180 block. Since there's not going to be a pattern, you can't tell if the PR interval is getting longer. You can't really tell. I guarantee you that that is winky block, and I'll tell you that for a couple of reasons. First of all, the QRS is narrow, and second of all, because the other is rare as density. All right. Third degree block. P wave, 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 P wave. Lots fewer QRSs. Oddly, very uncommonly, will this be the case, where the QRS afterwards is narrow. That's a junctional escape. Has to be, because it's narrow, right? The normal conduction system is being used. Smaller than 3 little boxes wide. The normal conduction system is being used, period. Has to be. There's no other physiologic way that can be. Commonly in the third degree block, there isn't. Usually it is a ventricular escape as opposed to a junctional escape, but in this case it is a junctional escape. Patient probably has LVH. Look at all that voltage, man. That's some voltage. All right. And now we've talked about normal conduction, partial conduction, no conduction, and then there's abnormal forms of conduction. The most famous of which is Wolff-Parkinson one. Now, what does that mean? It means that, so in the ring around the atria at the top, ventricles at the bottom, that encloses all the heart valves, in the center of that sits the AV node. It means that somewhere along that ring, there is a little piece of muscle fiber that connects the atrium and ventricle. And that happens embryologically as the chambers are forming and whatever else. There's just this little piece of muscle that manages to stretch itself across the cardiac skeleton. That's the fibrous tissue where the valves are all hooked to. And that little piece of tissue can usually conduct electricity because it's muscle, just like the rest of the heart. WPW requires the presence of a so-called delta wave. So classically, it's described as a short PR interval with a wide QRS, and then there's this sort of upsloping right from the end of the P wave into the QRS that makes the QRS interval long. It's really just that you're creating the ventricle is getting an impulse from 2 places, from the bypass tract as well as the AV node. And there's this sort of upsloping looking aspect of the QRS that's called the delta wave. It is correctly identified as a fusion complex. A fusion complex means that there are 2 two sources of electrical activity that are crashing together to create the QRS. In a one place you might see fusion complexes, for example, that is incredibly helpful is in the diagnosis of ventricular tachycardia. So as somebody has ventricular tachycardia, for example, you know, you have normal sinus rhythm and VTAC, right? So you have normal sinus rhythm, AV dissociation, and occasionally one of those P waves is going to happen to hit the AV node at a time when it's not refractory and conduct into the ventricle. And if the VTAC is fast enough, usually those two QRSs will crash together and create something that looks different than the typical VT QRS. And that's a so-called fusion complex. That is incredibly helpful because if you have a wide complex tachycardia and you see a fusion beat, done. It means there's AV dissociation and it's VTAC all day, every day. The diagnosis is made. It's not sinus tachycardia with aberrancy. It's